Good afternoon, everyone. Welcome all to today's session. Dr. Karingo Agnes from Kenyatta National Hospital Research Department. I'm standing in for Dr. Awak, and we welcome you to this ongoing series on pesticide toxicology and management of poisoning. I'll hand over the session to Dr. Jayesh Pandit, who is actually the pharmacovigilance country lead in Bayer East Africa, and he will give us his opening remarks and welcome our main speakers. We welcome you to give your questions, comments in the Q&A section, and you'll be able to go through them in the session and after the session. Welcome, everyone. Karibu, Jayesh.
Thank you so much, Dr. Agnes. Good afternoon to each and everyone on the call today. For me, it's a great pleasure to be able to co-host this with Agnes. Just before I give my quick remarks, a shout out to our colleagues from CropLife and AAK, Danson and Evelyn. If you are on the call, then please raise your hand so Agnes can bring you up to the panelist level. So that you can help us through the sessions. Okay, Evelyn's here, super. So good afternoon, everyone, and very warm welcome. Today is day 3, or should I say session 3 of our weekly webinars, which we started on the 4th of May. And as you heard Agnes say that I am a pharmacovigilance person, so I'm more hands-on on how to look at medicines working in humans and talk about the side effects of these medicines. But as we know, pharmacovigilance is an evolving field. We should also embrace what I guess we can call here with Wilfred today as pesticidovigilance, right? So if we can learn this, I believe we are, as healthcare workers, much more appropriately placed to look after our farmers, to look after the families of our farmers and the teams that work on the farm when they have a pesticide-related toxic effect to report and seeking ours, that's your and my healthcare intervention. So with not much any other further ado, I wish to invite Dr. Wilfred Stephens, who, as you can see, is a clinical toxicologist and a specialist in internal, occupational, and environmental medicine. So I believe he is appropriately trained to really guide us on what it takes when a patient came to our door with a pesticide-related issue. So over to you, Wilfred, and warm welcome to everyone. Thank you.
Thank you very much, Jayesh, Jumbo, and welcome to all. I'm very happy to be back for this 3rd session, which will actually be more medical than the ones before. And as you probably know, yeah, like that. As you probably know, physicians, doctors have their own language. I tried to keep it as understandable as possible, but well, when you're in the job for decades, you use, well, uncommon words for normal people quite often. So if there are real understanding issues, please let me know. We have day 3 today. Active ingredients part 2, that's a big word because part 1 last week was only the pyrethroids. Now we have the rest. I hope we can do it all in this session. So next week will be non-pesticidal, as there has been a request to include heat stroke and snake bites. That's why we call day 4 When Nature Strikes, but that's next week. We will speak about active ingredients today. The following, the presentation refers to acute intoxications and their treatment only. It does not deal with chronic exposures, repeated long-term exposures and their effects. And the other disclaimer is that we only cover either active ingredients that are used in bioproducts registered in Kenya and substances that have become generic but are so toxic that it's worthwhile to talk about them, like organophosphates, carbamates, or the phosphides. In this session, I have suggested to do it differently than in the 2 sessions before. I know from my own experience, when we're done with the session, I at least would have difficulties to remember what was my question for the very first topic. So there will be 5 minutes, not more, for questions after each substance or substance group. Again, only on acute poisoning with the group or substance just discussed. I have put in slides to remind me in case I get into a flow of presenting and forget about this intent. Other questions and questions that would need long replies can prompt discussions or require replies by Benson or Evelyn. We should and will answer in the final Q&A session. So please put your questions preferably into the Q&A part or raise your hands. The moderators will follow that too if I should not notice. So then, without further ado, let's start with a very toxic group of active ingredients no longer sold by our company, at least not in class WHO class 1 and 2 products, or not in products which would have toxicity, an LD50 of up to 50 milligram per kilogram body weight. The mode of action of organophosphates is the inhibition of esterases. You may remember last week I talked the carboxyl esterases in the skin when speaking about pyrethroids, but this is neglectable. It's more anecdotal, but important are the acetyl and butyrylcholine esterase and also the brain choline esterase, which is the cause of or the target for some CNS effects, but cannot be measured. The acetylcholine esterase can be measured in red blood cells, and the butyrylcholine esterase can be measured in serum. The inhibition will be persistent. In some cases, it's really permanent, so to say, as long as the red blood cells live, which is about 120 days. And can only be revised in some cases by an oxime. An antidote, will come to this later. Actually, acetylcholine is the transmitter substance in the synapses between the nerve endings, these circles. They are excreted by the first nerve, bind in the synapse to the second nerve, and then the excitation as an electrical impulse is forwarded. Acetylcholine esterase usually breaks down the acetylcholine, so there is no overexcitation. If the acetylcholine esterase is inhibited, like by an organophosphate or later by a carbamate, there's an accumulation of active acetylcholine, which is no longer inactivated, and so we get a strong overexcitation in the efferent in the second nerve, which will lead to the symptoms seen in organophosphate poisonings. In Kenya, quite a lot of organophosphates is registered, some of them being WHO class 1B. And they have an effect both on muscarinic and on nicotinic acetylcholine receptors. The muscarinic receptor causes meiosis, which means pinpoint pupils, lacrimation, so tears are flowing, vision problems like blurred vision, strong salivation, so production of saliva in the mouth, hypotension and bradycardia in the framework of reaction of the organism. Tachycardia can happen, but first it's always bradycardia. Strong bronchial secretion, which may fill up the lung, at least partially, and bronchospasm like in asthma. In the gastrointestinal tract, it's nausea, vomiting, and diarrhea. and on the skin, it's profuse sweating. So to remember this, everything is flowing. Stimulation of the nicotinic nerve endings results in muscle fibrillation that looks like many small worms crawling quickly, relatively fast under the skin. This is fibrillation of the muscles. There may be muscle tics, myoclonus, a cramp, paralysis of respiratory muscles with respiratory failure of peripheral causation. In the central nervous system, we can expect somnolence, coma, respiratory depression and failure, also hypothermia and convulsions. Laboratory analyses are or have been possible, but there are shortcomings. I don't expect them to be possible in rural health centers or in dispensaries. Only in some cases, probably in first-level hospitals. Let's start with the butyrylcholinesterase in serum. This is quite easy to determine. Normal autoanalyzers in large laboratories, obviously, can analyze it, and single tests for this, bedside tests, point-of-care tests, are becoming available. They are announced for the next month here in Germany, and but I don't have any clue how long it would take until they are available in Kenya. Problem is the butyrylcholinesterase in blood is synthesized in the liver continuously, so it is prone to changes due to liver diseases, alcohol intake, medication intake. As a surrogate, a 30% drop from normal values for the respective test can be used to decide upon therapy together with typical symptoms. So if a patient is, let's say, completely dry, so nothing is flowing, like I said before, then there should be no antidotal therapy at all. Acetylcholinesterase in red blood cells is very reliable, but one of the reagents is no longer made and not available. There is an automatic device developed by the German army on the market, but this is prohibitively expensive, and transport to lab centers of blood samples would delay the diagnosis and the urgently required treatment. You may wonder, why is the German army interested in pesticides? Well, clearly it is not. But there is another branch of organophosphates like Soman, Tabun, Sarin, VZ, and VX, and maybe also Novichok, which is not quite clear. So some of these are warfare agents. The acetylcholinesterase would be perfect for diagnosis because it is genetically determined and will not change. So in this case, a 30% drop is highly alarming. We used to do tests in industrial workers after 3 months of non-exposure to have a baseline. If there was batch production, which usually was in decades ago, so for a few months it was made, produced, and then after 3 months of non-production and non-exposure, the baseline value could be reassessed. The treatment, it starts with decontamination. I told you last week about the slight organophosphate poisonings I had myself as a nurse's help after washing down patients with severe organophosphate poisoning, because it is also excreted through the skin, not only contaminated skin, but also excretion on the skin. You would need nitrile gloves. Neoprene would be even better, but certainly they are not available that easily. PVC gloves do not give sufficient protection. Organophosphates will go through vinyl. If there is a very severe contamination, for instance, if the patient is full of bluish vomit, because many of the products are colored blue, then you may need protective overall and maybe even a filter mask, because you can also inhale organophosphates. Skin and eye decontamination to be done with water and soap. Interestingly, at a slightly alkaline pH, so above 7, organophosphates will be destroyed, both on the skin and on equipment, for instance, in emergency rooms. So washing with alkaline soap would destroy organophosphates. Then again, everywhere we have this skin-friendly soap with a pH which is slightly acidic, 5.5 for instance, and this does not help against the organophosphates. How about induced vomiting? Under the conditions I mentioned last week, only if it's at least a mouthful of concentrate less than an hour ago, and if the patient is fully conscious, so not somnolent, and never for emulsion concentrates and other preparations containing solvents, because these can spread on wet mucous membranes down into the lung, as you see petrol on a puddle of water, this colorful surface that you get. The same happens in the airways. Gastric lavage may be required if there's a significant ingestion, very significant ingestion and severe signs of poisoning, but it must be done under protection by intubation or at least a larynx mask, and also as quickly as possible. Activated charcoal can be considered and given. Cathartics are no longer recommended because they can cause electrolyte imbalances, like I told you last week. This is one of the very few cases where we have an antidote. We even have two, but one is really important. This is atropine. It should be used only if there are clear symptoms, as mentioned above, for the nicotinic and muscarinic receptors, and the serum cholinesterase is below 30% of normal for the test. You see here the latest recommendation for the treatment regimen. For adults, you start with 2 milligram atropine intravenously. Then you wait for 5 minutes. If the symptoms persist and do not decrease, you give 4 milligram IV. You wait 5 minutes. If the symptoms stay on, you give 8 milligram. After 5 minutes, you check again. If the symptoms persist, you give 16. And if there are still symptoms after 5 minutes, you give 32. You shouldn't give more, but switch to an infusion of 1 to 2 milligram per hour. Some may have the question, there is 0.5 milligram per milliliter in an atropine ampule. Yes, so either you need 3 nurses or nurses' helps to open all the ampules, but there are larger atropine ampoules which contain 10 milligrams, so that would be much more feasible. For children, the starting dose would be 0.1 milligram per kilogram, carefully repeated or increased, the dose increase, depending how the symptoms develop. So with children which react stronger both to the poison and to the antidote, more care is needed. And again, you must be absolutely certain that it is an organophosphate poisoning. I always tell here the anecdote from Germany where an emergency physician on the emergency car was called to a patient with suspected organophosphate poisoning, which the patient didn't have in the end. And he applied immediately 600 milligram of atropine, which actually killed the patient. So atropine is a poison in itself. And to cite Paracelsus, in some way, it only becomes non-poisonous if there is an antidote in the body, which the antidote to atropine would be the organophosphate. So if there are no clear symptoms or if the serum cholinesterase is completely normal, look for other reasons. Pinpoint pupils, for instance, you will also get from an opioid intoxication. There is another antidote, pralidoxim. which is supposed to reactivate the cholesterase in a group in some organophosphates, not in others, and only early on before this inhibition is fixed forever, which is called aging. It's not available in all countries, and if so, only in large hospitals. I'm not sure about the situation in Kenya, but I've included here the dose. Both starts with a bolus for adults above 12 and children below 12. Then infusion over 48 hours. In case there are seizures or convulsions from the organophosphate poisoning, same therapy as explained last year, benzodiazepine, which usually should be sufficient. If not, you can try pentobarbital. If not, sent to tertiary hospital for propofol narcosis. At least as important as antidote therapy, according to the regimens, is adequate intensive care therapy. Aspiration pneumonia and multi-organ failure are typically the final causes of death, and patients may die from these, even though the antidotal treatment with atropine has been perfect. Another issue is that 2 to 7 days after poisoning from some organophosphates, there may be the so-called intermediate syndrome IMS. This is first noticed when the patient is no longer able to raise his head or her head, and if there's weakness of the proximal limb muscles, there can be sudden respiratory failure due to muscle weakness. Mechanical ventilation may be required for 1 or 2 weeks, again or in addition. So again, if the patient had already been weaned from the initial ventilation, he may need it again, or it has to be extended. There is no specific treatment. What is required is mechanical ventilation until this intermediate syndrome fades away. What is this? No, it's not working anymore. Many years ago, we developed a very simple poster for rural hospitals. Back then, we started this in India with 2 acronyms, PROMISE and TREAT. So to remind the physicians and nurses of the telltale signs of organophosphate poisoning, pinpoint pupils, reduced heart rate, oozing of sweat, muscle twitching, incontinence, secretions like salivation, emesis, and nausea. And for treating them symptomatically, this is stabilize, decontaminate, evaluate the severity of symptoms, give the antidote, and then preferably take to a higher level hospital. The dosage regimen is also included here. And there are pictograms showing the salivation in the mouth should stop, the mouth should become dry, the sweating should end, the heart rate should become faster, lung auscultation should become clear, and the pupils should normalize and no longer be pinpoint. These are the sources. One publication from PubMed, and with the link in all these cases, the EPA paper that I recommended very much last week. So, are there questions on organophosphate poisoning? Let me take a look.
Yes, Wilfried, a couple of questions have come up.
Okay.
In the Q&A tab.
In the Q&A. Yeah. No, I don't see a question, sorry.
In the Q&A tab, there is one question that says, in case of OP poisoning on children and adults who has been rescued, what is the follow-up plans post-management?
Well, they will be stabilized after this. And then, well, they survive the poisoning if the antidotal and intensive care unit treatment, not only the antidotal treatment, has been successful, though, so there is, except intensive care and then inpatient observation, there is nothing else to be done. Nothing specific.
Okay, thank you. So there's a second follow-up question. Should you establish the duration of time the poisoning has occurred between the poisoning time and up to the time the patient was brought to the hospital?
Yeah, it makes sense to record that, but it does not influence treatment. So I said some of these organophosphates will age with the acetylcholinesterase, but you cannot recognize this. So in all cases that still show the symptoms, no matter how late they come to the hospital, you should start the atropine treatment and check whether this will improve or not.
Great, no thanks. And there's one more. What happens when IMS goes beyond 7 days?
Well, then you continue the ventilation. It will not become permanent. People will die without mechanical ventilation. So if this happens at home, it can be fatal because sudden respiratory arrest will be fatal before help can be there. But in hospital, then you have to extend the ventilation, but it would be very unusual if IMS lasts longer than 7 days.
Okay. If you do not have a baseline in cholinesterase measurement, what do you have to do?
Look for the telltale symptoms and treat accordingly. You're not correcting the acetylcholinesterase in red blood cells or the butyrcholinesterase in serum. You treat the symptoms of the patient. So in principle, you can live without these tests.
Sure. And maybe a quick last one as we then continue. Is there need for antibiotics in OPP?
Well, my view and the view of many other toxicologists is give antibiotics when required. So if you have the impression that there is an infection, which can happen here, there can be pneumonia after aspiration in particular. So if there are symptoms of an infection, then give antibiotics. I'm not a friend of prophylactic antibiosis because you never know which germ it will be.
Sure, and I guess because there's a follow-up to that, similar response would you have for PPIs and antacids?
Again, sorry?
For proton pump inhibitors as well as antacids. A similar approach is what you would take?
Yeah. Well, antacids you can certainly give, and also the PPIs. But well, this is symptomatic therapy. This will not change the course of the intoxication.
Okay. Repeat of atropine treatment from the initial dose and additional doses until full atropinization. I guess that was an answer, perhaps not a question. What are some of the home remedies for OP poisoning?
None. Unfortunately, none.
Okay.
So you have to give atropine, and for that you have to take the patient at least to a health center, if possible, a hospital.
And the role of fluid therapy in acute management of OPP?
Just to keep the kidneys working, there is no way to flush the OPs out of the organism. So no increased diuresis to be tried.
Okay. We are talking about atropine. How do you manage the extrapyramidal effects of atropine?
Well, by not giving too much. If you give too much, you will need an antidote against atropine, for instance, pyridostigmine or something. But you should be careful with the atropine.
So just to warn you, Wilfred, there are several questions coming, so we will have to manage time. One quick one, is there a maximum IV bolus in children before giving infusion of atropine?
The bolus would be 0.1 milligram per kilogram body weight, which you certainly can estimate. You don't have to put the child on a scale or on a balance, you just take a look. Well, this is 3 years old. It may be 7 kilos, so I give 0.7 milligram, and then you see how it develops onwards.
Okay. I think you spoke on this last week, but is there a contraindication for gastric lavage?
Well, not a serious one with the organophosphates. We have some substances later where gastric lavage is contraindicated. The patient must either be fully awake or he must have patent airways by using a larynx mask or intubation. I see here pardon?
Kindly guide the period beyond which pralidom can't be given.
Well, there is not a period when it cannot be given. But well, there will be a time for some organophosphates. They're all different, some of them are different in this respect when they do no longer work. But you can try them anyhow. Difference between organophosphate poisoning and carbamate. Carbamates are next.
Carbomates are next, yes. And what if there is obvious poisoning but no symptoms? Interesting.
Well, though, if there are no typical symptoms, it's not organophosphate poisoning. Then you must think about other poisonings. They may have similar effects, which, for instance, would be an opioid.
Activated charcoal, is it to be given even to children?
Yes, I said so. This makes sense. Yeah, activated charcoal. Oh, for children? Yeah, carefully, not too much. Last week I had a dose for the children. I think it was 25 to 50 gram. But that is in session 2.
Is there a window period for gastric lavage up to which there will be no benefit?
If it is a very severe intoxication, I personally would even try it like after 2 or 3 hours. I'm not in every case, only in very significant poisonings. On the other hand, with diarrhea, you can expect peristaltics to be increased, so the passage should be faster anyhow.
Maybe Wilfred, the last one, because we then need to move on, but please repeat on atropine treatment and how you scale up.
You start for adults with 2 milligram and then wait 5 minutes, then you double the dose, wait 5 minutes. If not successful, double the dose. Wait 5 minutes, if not sufficient, double the dose, and so on, but not more than 33 milligram.
Super. Thank you. So there are questions. I propose we come back to them as we now take up the next set of slides.
Okay.
Thanks. Oops. But thank you to everyone who's been
thank you for
asking questions.
For the interesting questions, indeed. What we can't do now, we'll do later. So, and now again, it moves on. Next one are the carbamates. The mechanism is the same as for organophosphates. Inhibition of esterases. So I have the same picture here again, but I don't have to explain that again. The measurement of esterases in red blood cells or in serum does not make real sense because the poisoning symptoms with carbamates appear very fast. The esterase inhibition will occur after even less than 5 minutes at very high doses, much faster than in organophosphate poisoning. On the other hand, it will last shorter, so it's a reversible inhibition. For instance, quite typical, you could say, is 1 hour to symptoms and 1 hour to recovery. Then again, in the short time of increasing symptoms and even after a few minutes, it can be fatal. Atropine is the only antidote. Oximes are not effective against carbamates. However, if you have a patient with acute organophosphate syndrome with clear signs and symptoms of inhibition of cholinesterase, and you don't know, is this a carbamate or is this an organophosphate, you can give oximes. Nobody will criticize you for this because you will help in the case of organophosphates and you will do no damage in the case of carbamates. It's just insufficient, ineffective. It's not toxic. There are, I think, 9 carbamates registered in Kenya. 2 of them are highly toxic, WHO class 1A, carbofuran and oxamil. The symptoms are largely the same. The difference is they appear very quickly, can be rapidly fatal, but if the initial phase is survive, do not last as long as with OPs. Probably there is no IMS, intermediate syndrome. I'm aware of one publication which described the case of IMS, but even the authors were not certain whether it really was IMS or had other reasons. Again, skin and eye decontamination, please remember using nitrile gloves because carbamates also will go through PVC. Induced vomiting, same, and gastric lavage, also the same. Activated charcoal can, maybe should be given. Again, cathartics are not really recommended. Treatment must start as soon as possible for carbamates based only on typical symptoms and if possible under monitoring or even in intensive care due to the high risk of fatality in the initial phase of high dose poisonings. Lab determination should not be the decision basis and it's not of interest. So, it's in principle, it's for historic interest. Because if you treat correctly with atropine, the patient will have survived and is out of danger until the lab result arrives. Again, large atropine ampules, otherwise it's the same regimen. Here we double until the secretion is stopped, the bronchoconstriction subsides, and the pulse rate and blood pressure ensure adequate tissue perfusion. So the blood pressure should not be normal then. Then you know the effective dose, like 16 or maybe 32. I would be very careful with going to 64, very, very careful. And then you give 10 to 20% per hour of the effective dose. So in this case, like 1.6 or 3.2 milligram as intravenous infusion. Again, 2 citations from which the information is coming. So and it's not possible if you don't have the packaging or a very reliable report to decide this is carbamate poisoning, this is organophosphate poisoning. Suggestion is to treat quickly based on the symptoms. You can do the cholinesterase measurements, but the deciding thing are the symptoms. Again, questions on carbamates. I have the questions now, so let's go to the real ones. Commonest organophosphate poisoning. This is already still to the organophosphates, but never mind. I can tell you, this will be different from country to country, which organophosphates are registered. The toxic ones, the tox class 1B, which you have in Kenya for organophosphate, in the worst case will be more toxic than class 2. Obviously, the intravenous fluid would be something like Ringer or saline, and I see no benefit of steroids. Yeah, the lavage can be done in a severe poisoning later than 1 hour of ingestion. I won't argue against that. The thing is that many toxicologists are of the opinion that gastric lavage has no advantage at all. I'm doubtful with this. At least a quick gastric lavage can make sense in these significant severe poisonings. Sorry, I can't say anything to paracetamol poisoning. This is not a pesticide and not very much in my focus. The blood sugar fluctuation may be due to the hepatic effects because, as you know, glucose is stored in the liver. So if the paracetamol dose have been so high that it's damaging the liver, then I cannot rule out that there will be fluctuation. Aging is an irreversible binding between an organophosphate and the acetylcholine esterase, which cannot be broken by pralidoxime, and then the patient will not get better from the pralidoxime. If you, well, as you guide the treatment by the decrease or the resolving symptoms, I'm very uncertain that you should give atropine because you see symptoms. It's certainly a good idea, but as I said, atropine is toxic. All that will happen to a patient with 2 milligram atropine, he will complain about a dry mouth. So it's not much harm, but then you may mask the symptoms, and in the end, you would have needed more atropine and are in false safety because the symptoms have been delayed just a bit by a low dose. So I would recommend to wait for symptoms. The time taken before the use of activated charcoal is the shortest possible. So when somebody comes with symptoms of organophosphate poisoning, or you could even discuss suspected organophosphate poisoning. I'm not recommending this, but it can be considered. Then you may give it even without clear symptoms, but at least as quickly as possible. Yeah, the milk question, do not give milk, as I said in each session and said again in the third session now, milk increases the absorption of lipophilic substances that are soluble in fat. So milk is not a universal antidote and should be avoided in poisonings. Okay, I think these were the questions. Then we come to the neonicotinoids. The neonicotinoids have a mode of action which is a competitive agonism on nicotinic acetylcholine receptors, not on the muscarinic ones. And as I said in the first session on the development of pesticides, these affect the alpha-4 beta-2 receptor in insects much more than the mammalian or human alpha-2 beta-2 receptor. What they do is they displace acetylcholine from the receptors and stimulate the receptor. Yesterday, I've tried to make a drawing for this too. So again, we have the acetylcholine and the acetylcholine esterase, which would do their normal work if there were not the neonicotinoid molecules, which bind to all of the receptors in the postsynaptic nerve and cause a strong overexcitation, which then will fade because the neuronal transmission will tire. There's a fatigue of the transmission. So it does not inhibit the acetylcholine esterase. The effects are similar if you smoke your first 3 cigarettes in a row. There may be a slight anesthetic effect, but the effects are like with cigarettes that you're not used to: dizziness, drowsiness, disorientation, agitation, coma, nausea and vomiting. The stimulation of the autonomic nervous systems may cause sweating, white pupils, which is a clear difference to the pinpoint pupils in organophosphate. So a sweating patient with white pupils should not get atropine. There will be tachycardia. Organophosphates primarily cause bradycardia, elevated blood pressure, no hypotension. And secondary, there may be coronary spasm and cardiac ischemia in patients with a predisposure for this. Nearly all severe cases seen have been due to significant oral ingestion, very often together with ethanol, so with drinking alcohol. Formerly, many of the products have been containing solvents and thus have been critical for induced vomiting. They can cause ulcerations in the upper gastrointestinal tract, but that has been due probably to solvent effects, in particular to N-methyl pyrrolidone. Dermal and inhalation exposure will result in mild intoxication, allegedly, but this is also questionable. One dermal contact has been fatal, a single one reported. All available neonicotinoids are registered in Kenya: acetamiprid, clothianidine, dineylfuran, imidacloprid, thiacloprid, thiamethoxam. They will, lactic acidosis has been seen only in 2 acetamiprid cases, not with the others. As I said, sore throat and ulcerations of the upper gastrointestinal tract is rather a solvent effect than a neonicotinoid effect. In the lung, dyspnea, chest tightness, respiratory failure in the worst case. After short bradycardia and hypotension, there will be tachycardia and hypertension with the consequences on the heart. Nausea, vomiting, diarrhea, abdominal pain, like when you smoke your first 3 cigarettes in a row. And in the CNS, disorientation, confusion and agitation, headache, drowsiness and dizziness, muscle weakness, tremor, and loss of consciousness. Treatment: wash skin with water and soap, irrigate eyes. Induced vomiting, never for emulsion concentrates with solvents, and many of the neonicotinoid formulations have been and may still have solvents. Gastric lavage is generally in literature not recommended, only in case of really life-threatening amounts and in the first 1 hour. Activated charcoal, yes. Cathartics, no. As before, there is no antidote. And please do not give atropine. Atropine is not an antidote for neonicotinoid intoxication. You will need cardiac monitoring already in moderate cases due to the risk of cardiac ischemia. And in severe cases, you should monitor the patient under intensive care conditions due to the potential of respiratory failure. Same medication as always for seizures, convulsions, benzodiazepines, in very severe cases, propofol. The literature, again, with a link to the EPA book. And are there questions on the neonicotinoids? Still an atropine question on organophosphates and carbomates. Until the patient is, so to say, dry. As explained in pictograms in this poster, if there is no more salivation, sweating, bronchial secretion, then it has been enough organophosphate. If needed, if symptoms reappear, you will give an infusion and use this again as long as needed. But let me say this again, no atropine for neonicotinoids. White pupil in poisoning, I'm not aware of what a white pupil in poisoning. You mean white instead of black? I never heard of that. Ah, white. Ah, okay. White pupils in poisoning indicate it's neither an opioid nor an organophosphate or carbamate. Nothing else. There are no neonicotinoids in common household substances, except there are solid baits for crawling insects that can be used indoors. So not as agricultural product, but there can be household insecticides. These are not dangerous. There will be no evaporation, so you will not inhale anything from these baits. You just have to keep them away from children and also from dogs. I like to say that dogs first eat and then think, if they think at all, but first they gulp down everything. The most visible common symptoms in nicotinamide poisoning are, like I said, Oh, this does not work, sorry. Does not react. There, okay. So the most common effects are, how to say, cigarette poisoning, the nicotine poisoning. The symptoms are very similar. And the common household agent with this effect would be a pack of cigarettes, actually. Amitraz, oh, interesting, common poisoning in Western Kenya, but all in all, amitraz poisoning is quite rare. I know it can be fatal and there is no role for atropine. I put down a note, so maybe next week I can say, for starters, before we come to the snakes, a word on amitraz, if it's common in Western Kenya. I wasn't aware of that. Okay. So this seems to be all. Okay. Then let's see whether the computer cooperates this time. No. Okay. The next group are the organochlorines, and here we take a trip back to history, or back in history, because many of these organochlorine insecticides have been banned, even long been banned, like DDT. Today there are only two for agricultural use still on the market, which are dicophol and endosulfan. Head lice are still treated with lindane, which is also an organochlorine. Again, this is not an agricultural use. Some countries still have DDT listed for surface treatment of dwellings, of buildings against mosquitoes. Obviously not in Kenya, at least I couldn't find it in the lists kindly provided by Dorothy. More than acute toxicity, the concern with organochlorines is their deposition in fat tissue and the resulting very long hard life. Also, persistence in environment and in humans. There is by now little impact regarding acute toxicity. For example, for dicophol, there is just one single case report. For endosulfan, there are more. And the fatality rate of a severe endosulfan poisoning has been reported to reach about a third, 30 to 40%. But this is severe. This is not all endosulfan poisonings. You have only dicophol registered in Kenya, neither endosulfan nor DDT for indoor use. Sorry. They will cause acute liver and kidney injury. They will cause rhabdomyolysis. They will cause hypertension, tachycardia, QT prolongation, lung symptoms with pulmonary arrest and pulmonary edema and respiratory arrest. Very commonly, endosulfan as an example, which you don't have, there will be seizures and convulsions and aberrations of several lab values. Oh, moment. For dicophol, there is only one case. In that case, had only nausea, dizziness, vomiting, confusion, and lethargy, was survived, but the last symptoms took 3 weeks to resolve. But it was a rather harmless poisoning compared to organophosphates and carbamates. Same thing as always for decontamination, for induced vomiting, and for gastric lavage. With the dicofol you have in Kenya, I have the impression that you don't need induced vomiting, and maybe not even gastric lavage, if so with giving activated charcoal. The respiratory or cardiac function should be monitored for several days. And as the seizures and convulsions are one of the main concerns, again, the benzodiazepines, phenobarbital, and even propofol come into the picture. You can give phenobarbital even as an oral medication. A dose of more than 35 grams of endosulfan is regarded as a predictor of potential mortality. Questions on organochlorines? Yes, absolutely. All questions are valid. Saw this in the chat. Does it go upward down or downward up? Upward down, okay. Well, if you give water not more than 1 glass, you will not vomit from 1 glass, but if you give more, you increase the transport from the stomach into the intestines where the toxin will be absorbed. So 1 glass of water. You can give salt water, also never more than 1 glass, and even less for children, to induce vomiting. The distinguishing feature for neonicotinoids will be the white pupils compared to organophosphates and carbamates. Yes, we'll come to amitraz. Yes, convulsants are effective if there are convulsions after or with organophosphate poisoning. Oh, the doses of benzos and phenobarbs is also in session 2, which I think is accessible on the KNH pages. So far, I found only the very first session on YouTube. So I'm not quite sure whether this second and the third one will also end up on YouTube. Yeah, I would have to go back to this. So if needed, we can do that in the end. Anticonvulsant doses, but it should be available on the KNH pages. Yeah, sorry, sodium valproate is also a medication, and this is not included. And frankly, I don't know, you would have called Poison Control Center or what you have, the Kenyatta National Hospital for this. Well, yeah, a question by Irene. Organochlorines are very persistent. And this will be long-term effects. We're focusing here on the acute effects of poisonings and what to do to make the patient survive. There are effects of organochlorines that are longer lasting. They, for example, endocrine disruption, and you may remember it all started with the eggshells of predatory birds becoming too thin. So these can be effects, but this is not in the framework of this presentation. The next 2 are not really for me. Which pesticides can be used to destroy ants? Well, many insecticides, but you have to offer them, for instance, in honey or something, which are the usual preparations for ant baits. Okay.
Allow me,
yeah, sure.
if I can just quickly invite Danson or Evelyn. Perhaps the fact that amitraz is coming up again, maybe you have a word or two as a local scenario, Danson or Evelyn? Evelyn, Danson is a gentleman. Maybe he meant ladies first.
Well, Jayesh, I will speak about amitraz upon popular request, obviously next week in the first place.
Okay. No, I just thought from a local scenario, maybe Danson or Evelyn had a point. Okay. No, that's fine. We can continue.
Yep, we will. Here. Oh, yeah. Okay. Same procedure as always. It doesn't want to go on. No matter what I press. Very sorry. Auch nicht. Neither the keys nor the mouse will help. Ah, now. Okay. Next group, Chlorophenoxy herbicides. Not very severe, but quite common. In the first place, the Chlorophenoxy herbicides are chlorophenoxy acid herbicides. So they're all acids, and ingestion will cause, on the one hand, metabolic acidosis, and on the other hand, it will cause corrosive burns in the esophagus. Bitte?
Hello, Wilfred. We are not able to see the slides.
Yeah.
Wilfred.
What is this? I just step out of the presentation mode and try again. Does this work now?
Not yet.
Oh. Now, yes? Okay.
Yes.
Yeah, these substances are acids.
Wilfred, you've gone to mute.
Can you hear me again?
Yes, now we can.
So metabolic acidosis and corrosive burns in the esophagus, they are weak uncouplers of the cell oxidative phosphorylation. So extreme doses can produce hypothermia, fever. Most cases, about 85%, are only minimal poisonings with mild gastrointestinal symptoms, nausea, abdominal pain, headache, weakness, and dizziness. Well absorbed the oral way, limited inhalation, and minimal absorption by the dermal way. This computer is not my friend anymore. I have no idea what's happening. Very sorry for this. Okay. You have a handful with these complicated names registered in Kenya. I noticed that there is some risk of confusing MCPP, also called Micopop, with another substance that's called Micopop, which is a drug of abuse, chlorophenylpiperazine, but this is totally different. So it's better to call it MCPP probably. They will cause skin, eye, gastrointestinal tract irritation, abdominal pain. They can do muscle injury, can cause muscle injury, I said metabolic acidosis, and they can cause CNS effects, most often from the MCPP and the 2,4-D. I noticed an interesting new paper that reports a loss of the taste of sweet in case of chlorophenoxy herbicide intoxication by inhibiting the according receptor. If this becomes confirmed, it would be a diagnostic sign, but well, probably it will never turn out to be a diagnostic sign. Washing, irrigation of eyes because the substances are corrosive. A substantial amount will provoke emesis, so no further emesis or vomiting would be required, and the substances are corrosive, and you remember, with corrosives, induced vomiting is prohibited. They are not that toxic, so gastric lavage is not recommended. As always, activated charcoal, yes. Cathartics, no. There is no antidote, so treatment must be supportive. Excretion must be increased. You do this by giving saline or glucose infusions, ringer solution, to achieve a urine flow of 4 to 6 milliliters per minute. Avoid fluid overload, so check the urine and lab values like serum creatinine and electrolytes. You can much increase the excretion of these compounds by making the urine alkaline. For this, you infuse sodium bicarbonate to an urine pH of 7.6 to 8.8. You don't want a caustic burn in the urine ways. This is called forced alkaline diuresis. You must also substitute potassium according to the lab values that you get. A last result of therapy would be hemodialysis. Let me guess, no questions on this. Well, yeah, twice the emitras, and I'll come to this next week, as it is obviously so important, which unfortunately I didn't know. Long-term effects, well, if we go into long-term effects of organochlorines, that would be a session of its own. Well, as said, this program deals with acute poisoning, so pardon me please for not addressing this. Down there, organophosphates again. Yeah, for instance, they are manufactured in developing countries today, Dr. Vagella. They are no longer manufactured in to a significant amount in the Western world. But as I said, there are all kinds of organophosphates coming into the market from China and India, and because they're cheap. The money that can be made with them has largely been made. They're cheaper probably than very recent and less toxic insecticides, and so they are used. We are doing our best not to sell them, but we are aware that they come into the market from India and China. In the first session, I told you of an example when methyl parathion was imported into a European country, to Spain, completely illegally, but it was cheap and effective, and so it was used. We'll come to glyphosate in 2 moments. It's not an organophosphate in the strict sense. Again, the same. Okay. So next one is ammonium glufosinate. This acts by reduction of GABA, gamma-aminobutyric acid, by enzyme inhibition. Mammals, also humans and plants, have different metabolic pathways to compensate for this inhibition, so it is relatively plant-specific. Significant poisonings have been only reported from oral ingestion, accidental and mostly suicidal. Nearly 30% of ingestions have been reported not to result in clinical signs, even in suicidal attempts. Problem with glufosinate ammonium is that neurological complications can manifest with a delay of up to 2 days, several hours to 2 days. And respiratory failure can occur between 1 day and 2.5 days. There are discussions whether the toxicity of glufosinate ammonium is due to the active ingredient, to the surfactant in the formulation, or to a combination of both. The ingestion of 100 milliliter of an undiluted formulation is regarded as being critical. So this would be like half a cup. Symptoms are muscle weakness, the usual abdominal signs. There is only practically one way the gastrointestinal tract can react, with irritation, pain, diarrhea, and nausea. They can cause both. It can cause both bradycardia and tachycardia and hypotension. In blood, metabolic acidosis and hyperammonemia. In the CNS, hypothermia, also very rarely, but seizures and convulsions, somnolence, coma, respiratory failure. I think I have to shorten the treatment, which is always the same for decontamination, induced vomiting, charcoal, gastric lavage. There is no antidote for glufosinate ammonium, so treatment can only be supportive. Typical convulsion therapy. Extracorporeal elimination is under discussion, hemodialysis, hemofiltration, but there are reports of severe neurological signs during hemofiltration with decreasing serum levels of glufosinate, so caution is advised. There is one single report of effective lipid emulsion therapy. This means you give an infusion of lipids like you do for artificial nutrition, and this binds the toxin. This has been tried for glufosinate, but only a single case has been reported as effective. The delayed onset of neurological complications requires inpatient observation for at least, I would say, 48 hours. Questions on GA, glufosinate ammonium? Risk of eating raw or undercooked vegetables which have been sprayed 1 or 2 days after spraying. Well, this is not correct use, because the farmer learns about the time, the so-called latency time, in which the fruit, the crops cannot be eaten. After this, UV light, air will destroy the herbicides or wash them down, except obviously for the organochlorines, which are a dying race. So, well, certainly there can be a risk if raw fruit are eaten or vegetables, but well, this is not the idea. This would be clearly a mistake. This is so strange. Yeah, okay, now we come to glyphosate. Glyphosate has a very low toxicity, acute toxicity, and that's what we're talking about here. The LD50 is below 5 grams per kilogram. It contains phosphor or phosphorus, but it's not an organophosphate like the organophosphates. These cannot be compared. And please stay clear of atropine in case of glyphosate poisonings. It's used as salts, usually the isopropylamine salt, but there are also potassium salts. It inhibits the mechanism of action. The mode of action is inhibition of a plant-specific enzyme, which interferes with amino acid synthesis. If you look at the name, you'll understand why I don't want to pronounce it. This is a mechanism that is not present in humans. Significant poisonings with glyphosate formulations have only been reported in intentional oral ingestions. Dermal contact and accidental small dose ingestions have been causing only mild symptoms. More than mild were only 5% of cases in a severe study, and this includes moderate, severe, and fatal. So 94.5 cases of glyphosate ingestions are mild and not critical in any way. Then again, an ingestion of more than 85% of a glyphosate isopropylamine formulation can cause serious poisoning. More than 190 ml can be fatal. Death can be due to respiratory failure, cardiogenic shock, or multi-organ failure. In particular for glyphosate, there are discussions whether the acute toxicity is at all due to the active ingredient or to a surfactant in the formulation, or to a combination of both. The symptoms are once again metabolic acidosis. Here we can see mucosal bleeding and hypovolemic shock in severe ingestions. There can be heart effects, there can be respiratory distress and lung edema, renal and hepatic impairment, probably due to the reduced perfusion with blood, and CNS effects are also possible, and they are an indicator of a severe course and potential fatality. Yes, decontamination induced vomiting is not recommended as the poisonings are not that serious and the toxicity of glyphosate itself is very, very low. Activated charcoal can be considered treatment supportive. There is no antidote. Should there be convulsions, typical therapy with benzodiazepines, phenobarbital, and in the end propofol if needed. Extracorporeal elimination seems to be beneficial, most so hemofiltration, but as always, this is under discussion. I think the toxicological knowledge is always under discussion. There are a few reports again of effective lipid emulsion therapy. Yes, these are the sources. And for glyphosate, I would think there will be questions. Yes, the carcinogenicity of glyphosate, if at all existing, is a long-term effect. I talked about the agricultural health study, which is observing a huge number in the tens of thousands American farmers and families in the USA. And in that study, glyphosate came out clear. The regulatory authorities, even those addressing hazards and not risks of chemicals, have come to the conclusion that glyphosate is not a carcinogen. So this is on the one hand scientifically unclear, and on the other hand, it's an ongoing lawsuit, so not much can be said on this either. Sorry, I have always to interrupt my presentation and then restart it. Don't know what happened to my computer. So these are now the only WH1 class pesticides that we're talking about. The anticoagulant rodenticides. In the case of Kenya, it's only the superwarfarines, so the extremely strong ones. They only require a single ingestion by the rodents, are stored in the liver, and cause very long-lasting bleeding issues. As all warfarines, as all anticoagulants, they work by depressing the vitamin K-dependent blood clotting factors 2, 7, 9, and 10. They have a relatively long half-life, so rarely symptoms, and only at extremely high doses will appear in a few days. You can easily check this by determining the INR, the international normalized ratio, to see the antiprothrombin effect. This is a common blood test that certainly each laboratory, each medical laboratory can do. Oral ingestion is the only reasonable route of exposure. In factory workers, a few cases of mild intoxications have been described from dermal contact, but as always, you can completely avoid this by using PPE. Well, oral ingestion in the vast majority of human cases, this means suicide or suicidal attempts. Quite often toddlers may ingest a small dose, grains or pellets, which usually is uncritical and will not cause bleeding. Also, the amount of active ingredient in rodent bites is low, so a significant amount must be ingested. The only creatures that tend to ingest huge amounts are dogs, and we have been made aware of lots and lots of poisoned dogs. You have 4 of these superwarfarins, which are all W class 1A, but in the products, in the formulations, be it grains or baits, The concentration usually is 0.0035%, so very, very, very low. Symptoms is bleeding everywhere where you can bleed, also into organs, so that death may result from intracranial bleeding, bleeding into the brain, or shock from bleeding. Only 2% of cases show bleeding issues at all, and mortality is even more rare. The antidote for these substances, well, you can decide upon the required treatment by measuring the INR, the International Normalized Ratio, 36 to 48 hours, also before that. But if after 1.5 days or 2 days, the INR is normal, no further action is required. If you're careful, you will do it again a few days later, but you don't need to give the antidote, which is vitamin K1, not 3 or 4, which are more for cosmetics. The dose is between 10 and 100 intravenously. And due to the extremely long half-life of these superwarfarins, which has been used for killing rats and mice, the chronic maintenance has to be done with like 100 milligram K1 per day for an average of nearly half a year, about 170 days. Monitoring to be done again by the INR. In severe cases, you may need further hemostatic therapy, like application of prothrombin complex concentrate or recombinant factor 7A. So we're speaking in this case clearly about university hospitals. If there is a significant loss of blood, obviously you will need to give transfusions. But as said, in humans, this is very, very rare, where in contrast in dogs, it is not really uncommon. Questions on this? Evan-AC, no, is empty. No, now I do it differently for in the first place. Oops. Chlorophenoxy, interesting, much further. So the last group that we're coming to are the phosphides, which are also quite common poisonings, especially in the near to Middle East and India, South Asia. Also, yes, thank you, Margot, for reminding me of this click. Aluminium.
Wilfred, you've gone on mute.
Now it should work. Strange, the computer has a life of its own. Aluminium phosphide is used as a rodenticide and as a grain fumigant. It's very toxic, acting by liberation of phosphine gas, pH 3, and also diphosphine when it comes into contact with humidity or acids, water or acid in the stomach. Same for zinc phosphide. Phosphine will be exhaled and can be a risk for attending medical personnel. So in severe cases, you must consider using respiratory protection. There are some reports of self-ignition of exhaled diphosphine causing facial burns in the patients. The fatality rate is very high, 40 to more than 90%, and there is no antidote. What is more, the exact toxicological mode of action is not clear. There is a disturbance of cellular metabolism, but nobody really knows why. Both phosphides are registered in Kenya, and they will cause ulcerations, retrosternal and epigastric pain, cough dyspnea, pulmonary edema, breathing failure, treatment refractory hypotension, tachycardia, arrhythmia, conduction disturbances, and cardiogenic shock. the usual gastrointestinal symptoms, and the exhalation of phosphine, which is dangerous for everyone around. Renal failure, hepatic failure with jaundice, and disseminated intravascular coagulation can occur. If you use water for decontamination, you have to use large amounts as it will create phosphine. And do not give water to drink to the patient. This will increase the phosphine liberation in the stomach. No induced vomiting due to the corrosive effect, no gastric lavage. Some suggestions are there to do a lavage with vegetable oil or castor oil, but these are single casuistics. Hypotension must be treated with crystalloid solutions and with vasopressors, which actually are indispensable in these poisonings. As usual, metabolic acidosis requires bicarbonate application. The heart function can be so impaired and difficult to treat that there are recommendations to use extracorporeal membrane oxygenation or intra-aortal balloon pump, which are not realistic scenarios for rural and even small town hospitals. So only standard supportive treatment can be given, and it's difficult to decrease the very, very high fatality rate. Well, both are not pesticides. They are used in households against algae, for instance, but well, they are not part of this pesticide presentation. This concludes my presentation. Sorry, it took a bit longer, but I think we replied to a lot of the questions already by now. Here are the contacts, as in the last presentations, that you have available in Kenya. A final invitation to join the Bayer Safe Use Ambassador Program, which is meant to be an exchange platform on which we from Bayer can also reply. And I thank you for your interest, for your attendance, and for the interesting questions. We still have, I think, 5 minutes or so for more questions.
Thank you so much. Yeah, thank you so much, Wilfred. Been an excellent session from where I've been.
Everybody still there?
Yes. Yes, can you hear me?
Yes, you can.
Can you hear me? Yeah,
yes, we can, yeah.
Super. No, so I wanted to say a big thank you, Wilfred. And I do have Benson, I have Margot, we see Dr. Tao as part of our panelists. Anyone
no
has any quick
anymore?
input?
Obviously not.
No questions.
Okay,
so
no questions.
Maybe a quick word from my side. Big thank you to all our participants.
Tomorrow's.
Hörst du Jaish nicht?
A big thank you to all our participants.
Program.
Today we clocked 1,000. We clocked the final figure of 1,000. So I guess no more could come in.
What is this now again? Can you try again, Jayesh?
Yeah. Can everyone else hear me? Can I be heard?
Yes, we can hear.
Okay.
You can hear me. Super. So no, I just wanted to say a big thank you to all the participants. You've been very active. I think we had a record about 60 questions and answers answered within the same period. So hats off to you for not being shy and kept on asking, and well done to Wilfred for backing all of them through.
Thank you.
And big thank you to Agnes for allowing us this space. I'm not sure if Dorothy is back. Any idea if Dorothy has joined in? If not, then in absentia, big thank you, Dorothy. And just before I hand over back to Agnes to introduce this slide to us, a quick reminder that the last session on this will be next week. And just like Wilfred said, it's a very interesting session, when nature strikes. So please remember, join us as we discuss common issues around heat stroke as well as snake bites in our farmers, in our families. So thank you all so much, and over to you, Agnes.
May I also say thank you for your interest and your participation. And next week we'll talk about when amitraz and nature strike.
Sure.
Thank you. Thank you so much, Wilfred. Thank you, Dr. Jayesh. We really do appreciate this session. It has been one very informative session. We do thank you, our participants. And you're welcome to join us for the upcoming sessions. As we've heard, we will have a similar session in the coming week, in the coming Wednesday, and you are all welcome. For the slides and the presentations, we upload them at the KNH website, and you'll be able to access them from there. And we have CPD information that you'll be able to see on the screen. But for any questions on CPD, you can email us at knhcpd@gmail.com. So we thank you all. Do have a lovely evening. Thank you.
Thank you. Goodbye.
Bye-bye.
Goodbye. Ja. Wenn du mir nur aufmachst, oder? Also der ist für nebenan. Okay. Gut, gut.